Welcome, everybody. I am Dr. Shannon Dowler. I'm with the Office of Infectious Disease and HIV/AIDS Policy. Thank you for participating today in our fourth webinar of the Stopping Syphilis HHS Summer Seminar Series. Before we begin, at any point, if you need technical assistance, please contact the chat for the meeting host or the panelists to help you out. So this is one of 6 hot syphilis summer webinars we've been hosting over the summer on different topics related to syphilis. Today's webinar is going to focus on doxycycline as treatment and prevention for syphilis. Doxy is one of our oldest antibiotics, coming onto the scene in the 1960s. It's been a critical treatment from things such as Lyme's disease and other tick-borne disease all the way to acne. Today, we're going to talk about how it is providing one of the newest sexually transmitted infection prevention strategies in our toolbox and has been critical in navigating the syphilis and congenital syphilis syndemic. Today, we're going to be joined by Dr. Lindley Barbie, Chief Medical Officer from the Division of STD Prevention at the CDC, who's going to go over what we've learned about doxycycline use for treating syphilis, a treatment we relied on when benzathine penicillin was in short supply, and the evidence behind that treatment. And she's going to teach us more about clinical guidelines on the use of doxy post-exposure prophylaxis, DoxyPEP, for bacterial STI prevention. We're going to wrap up with some clinical scenarios on the use of DoxyPEP. Over the course of the webinar, please feel free to submit questions in the Q&A, and we will address them as we go throughout the webinar and at the end in the question and answer session. Now, I was in Mississippi last week for a meeting, and I passed this sign. I thought I was pretty committed when I named one of my baby goats Doxy, but clearly Mississippi's a step ahead. They have an entire state park dedicated to Doxy. So of course I pulled my car over on the side of the road and I took this selfie. Mississippi, you have stolen my heart. Before I turn it over to Dr. Merman, Director of the National Center for HIV, Viral Hepatitis, STD, and TB Prevention, to provide opening remarks for today's discussion, let's see who's in the room. As always, we like to use our audience response questions to connect with you better and understand where you are. So please take a second to answer this question as it pops up. So question 1 for today: which of the following categories best describes your professional role as it pertains to syphilis? Are you a clinician providing direct care? Maybe you're a clinician that's reviewing and signing off on the work of others. Perhaps your clinical support staff, outreach and education, disease intervention specialists who have my heart. Maybe you're an administrator, a funder, a payer, or some other public health professional. Or maybe you're a Greek scholar and you thought this was a Sisyphus webinar, not the syphilis webinar. So who are you? Who's in the room with us today? Damon, what do we have? There we go. All right. So we've got a blend of folks. And my disease intervention specialists are in the house. Yay. But lots of other different types of folks as well. Lots of public health professionals. No Greek scholars this time. Good. So we got the right group. All right. With that, I am going to turn it over to Dr. Jonathan Merman.
Well, thank you very much, Dr. Dowler. I really appreciate joining the webinar and your openness in showing your vandalism of a state sign for the sake of syphilis prevention. So I wanted to highlight just an introduction to the webinar that syphilis is a public health crisis for the United States. We've had over 200,000 cases. The last year we've had data available, including over 3,700 cases of congenital syphilis. And in the past 10 years, we've had a 222% increase in primary and secondary syphilis across the country, and congenital syphilis cases have increased almost 1,000%. So the world has seen increases in syphilis, but the increases have been particularly severe in the United States. And all of us who've kind of joined the webinar know that STI work prevents infections and saves. It prevents morbidity associated with syphilis. It also saves money. Current estimates are that the annual incidence of STIs in general cost about $17 billion in lifetime medical care costs. And as a community, we've prevented thousands of cases of congenital syphilis through screening and treatment during pregnancy. However, current efforts are not sufficient, and we've been losing ground. And I think that's been particularly challenging for those on the front line who see the ramifications of our inability to really jump ahead and tackle the problem. So we have been fighting back with the same weapons as 100 years ago, whether from diagnostics, treatment, or a prevention standpoint. And as Shannon mentioned, the good news is that penicillin still works. And although we've had periods of restricted supply over the past decade, currently there's ample supply of bicillin in the US, and it remains the first-line treatment. And Dr. Barbie will discuss the effectiveness of other medications, including doxycycline and ceftriaxone, but bicillin should be available and used in the United States. There are, however, new uses of our 60-year-old drug, doxycycline, and today we'll hear about trials that have definitively shown the efficacy of doxycycline post-exposure prophylaxis, or DoxyPEP. Taking a single dose of 200 milligrams of doxycycline within 72 hours of having sex. It's been associated with decreasing the risk of getting syphilis, chlamydia, and gonorrhea by about 2/3, with somewhat lower effects on gonorrhea than the other infections. And there's also initial data from one city showing that expanded use of DoxyPEP in 2 clinics had citywide reductions in syphilis and chlamydia. So there are many questions that remain regarding the use of DoxyPEP. And Dr. Barbie will touch on a number of them, including whether it is effective among cisgender women, whether it will have community-wide benefits, whether it will reduce the incidence of congenital syphilis through reductions in secondary infections, whether it's associated with increasing antimicrobial resistance in a meaningful way, or will it have negative effects on the microbiome, and how best it can be implemented over time. However, I do want to say it's the first major prevention intervention that we have for syphilis since the discovery of penicillin, the implementation of contact tracing, or perhaps the invention of condoms. And doxycycline is a familiar drug for clinicians and patients, and it's inexpensive, facilitating its potential use in disproportionately affected populations. So lastly, I wanted to highlight that the current CDC recommendations for DoxyPEP are focused on MSM and trans women because these are the only populations for which there are data of effectiveness from randomized controlled trials. There's ongoing research in other populations. Syphilis is vastly more common among MSM and trans women than other populations, and initial efforts could readily be focused on expanding use among eligible people with HIV and taking HIV PrEP. So the populations that are already visiting physicians regularly and are at considerably higher risk for syphilis because of the community prevalence. So if we wanted to implement DoxyPEP rapidly, these are some of the populations that we could do so and know we're making a difference. I also wanted to say that CDC was fortunate to be provided resources through the Office of the Assistant Secretary of Health to implement expanded use of DoxyPEP in the jurisdictions most affected by syphilis. And I'm grateful for the tremendous interest in this webinar and the work of many of you for years who have worked to prevent and treat syphilis and other STIs. And I hope we're at a turning point. And now I'll turn it back to Dr. Dowler.
Thank you. Thank you so much for being here and being on the webinar with us today. I think we've got a polling question, and you know I love polling questions, so let's see. This one I think is the one we've used several times, so you guys should all get it right now. Now that benzathine penicillin is widely available, treatment guidelines have reverted to using bicillin for all patients without a contraindication. Is that true? Or is that false? Is that true, or is that false? All right, let's see what people said, Damon. Did they get my body language? Yay, we're getting better. Every webinar, we're getting better. So yes, 74% of you know now you should be able to get your orders. 2.4 million units are widely available. There's no delay from the manufacturer, and you should be getting those. I think, Damon, we have one more polling question. Yes. So just before Dr. Barbie kicks off, I want to know, for those of you, are you, or is your clinic already incorporating providing DoxyPEP into practice? It's just a yes or no question. Are you guys doing it or not yet? And we're just curious about the audience and what your experience is right now. So easy yes or no question. Damon, let's see what people said. All right, perfect. So about half and half. So some of you guys are thinking about it. Some of you jumped on right away. Fantastic. With that, I am going to turn it over to Dr. Barbie.
Thank you, Dr. Dollar and Dr. Merman. It's really a real pleasure to be here today to talk about doxycycline, which is really just an incredible antibiotic. So as Dr. Dollar mentioned, doxycycline is a second-generation tetracycline. It's been available since 1967. And it's really an excellent antibiotic for a number of reasons. One, it just works really well. So it's excellent bioavailability, meaning that when you ingest it and it goes into your stomach, almost all of it is absorbed and goes into your plasma and becomes concentrated in the plasma. And then from there, it has excellent tissue penetration, which is where it does its work to kill bacteria. It is a bacteriostatic antibiotic, which means it actually inhibits protein synthesis and prevents bacteria from reproducing, which is different than bactericidal. So it doesn't actually kill it directly, but it's more of an indirect killing for not letting it reproduce. But one of its most important properties is that it is an oral drug. There are very few oral drugs that have such broad spectrum, meaning they cover a lot of different bacteria. This means that for patients who are maybe in the hospital and getting IV medications, if it's the right drug for them, they can switch to an oral drug early and get out of the hospital. Or maybe you don't even have to go in the hospital to begin with. It's really well tolerated, very safe drug. You don't need to monitor blood levels or kidney function or liver function. It's really just a great drug, and it has been used for many, many infections. So here I'm just listing them so you can get a wow sense that it is used for so many different infections. The dark green with the white writing are places where it is really the best choice drug, and the light gray bars with the black writing is where it's kind of like a second tier drug. But you can see where it is the first choice for community-acquired pneumonia, CAP, for both typical, atypical, and atypical related to zoonotic or infections that come from animals. But it's also the first line drug for a number of our kind of weird, as us ID docs sometimes say, some of the more out there infections that are rare. In fact, some of us ID docs like to say, never let someone die from an infection without trying doxycycline, because it really just is a great drug. It's a great drug also for syphilis. And I'm just going to share a little bit, when I can figure out my computer here, on how it's recommended across the globe. So here we're looking at recommendations for doxycycline use for syphilis by 4 different major guidelines recommenders by nation. United States is on the left, United Kingdom, Europeans, and Australia. And everybody does recommend it as an alternate treatment, primarily for penicillin allergy, as you can see for the US, Europe, and Australia. The UK recommends it without constriction to penicillin allergy. And the Europeans also allow for people who refuse IV or IM infections. Almost universally, it's recommended as 100 milligrams twice daily, 14 days for early syphilis. So that's primary, secondary, and early latent syphilis, syphilis of less than 1 year. Or 100 milligrams twice daily for 28 days for late, latent, or unknown duration syphilis. I will note that the British actually have a recommendation for neurosyphilis as well, which is 200 milligrams twice daily for 28 days for neurosyphilis, and they are the only ones with that recommendation. But what really is the evidence behind this use? There have been 3 systematic reviews and meta-analyses on this topic in the past about 7 years. There's very minor differences in these systematic reviews based on kind of the inclusion criteria of what studies they included, the outcomes they measured, whether it was 6, 12, 24 months, whether it was just early syphilis or all syphilis, and they vary a little bit on the numbers included, but they all came to the same conclusion. The first one, which was published in 2017, included 9 records, which included 267 individuals treated with doxycycline or tetracycline, compared to over 1,600 patients treated with penicillin. They used only early syphilis and looked at an outcome of serologic response at 12 months. And as you can see, there was really no difference in serologic response between penicillin and doxycycline, penicillin and ceftriaxone, or doxycycline compared to ceftriaxone. And I do need to note that there are no randomized controlled trials on doxycycline versus penicillin. These are all observational trials, so real world outcomes. The second one was published in 2022, very similar, except they looked at outcomes at both 6 and 12 months. They also did a network meta-analysis, which allowed them to compare the ceftriaxone against doxy, even though there's no trials looking at that, by imputing the data between the ceftriaxone and penicillin and the doxy and the penicillin. And you can see here, same results, no statistically significant difference between doxycycline and penicillin. And if you scroll down on that forest plot, you can see there's no difference between ceftriaxone and doxy either, which is just some added data for you today. The last one was just published in March or April of this year and had the most patients. It almost doubled the number of patients treated with doxycycline to almost 500. And the penicillin comparator was over 2,100. Interestingly, they used whatever serologic response the original study defined. And again, all observational trials. Very similar response here are the 9 studies that were included for doxycycline. And as you can see, there's no statistically significant difference in outcomes using serologic response, meaning that the RPR went down by 4-fold or 2 titers. I think Dr. Dollar has a question on this one.
All right, let us launch an audience response question. So when we look at adherence and we think about whether people take medicines the way we prescribe them, studies that have evaluated medication adherence in the treatment for chlamydia with doxycycline have demonstrated which of the following. People always follow doctor's orders. They never follow doctor's orders. We've never actually studied it. People definitely miss doses, or treatment frequently fails due to non-adherence. So what do you think happens when we have studied medication adherence with chlamydia specifically using doxycycline? Damon, what do people say? All right, very interested. So Lindley, take it away.
Thanks, Shannon. And interesting results also. We're here to talk about syphilis and not chlamydia. So I'm going to say that there actually are no published studies on adherence to doxycycline for syphilis. There are, however, as Dr. Dollar said, doxycycline adherence studies for chlamydia, and it's true, people are not very good with taking their doxycycline for 100% of the time, but they do take it a good proportion of the time, most of the time, and whether that involves them missing a single, the evening dose one day, or a couple doses at the end, it really varies. And in the case of syphilis, if we can apply what lessons we've learned from doxy adherence to chlamydia treatment to the syphilis, we need to remember that the studies that I just reported on were all retrospective. They were real world compliance, and surely they did not take all 28 pills or 28 days of pills, or 28 pills for the 14-day regimens. So it makes you come back to the part that says, do we really know how much doxycycline we need and how long you need to take it for it to be effective? And we don't. It seems to be effective regardless of the adherence. So my take-home message on doxycycline is that it's pretty comparable to penicillin for the treatment of syphilis. Penicillin is great because people don't have to take it twice a day. But when you have to use doxycycline, it can be very effective.
All right, let us jump to a polling question. True or false? Prescribing HIV PrEP and Doxy PEP at the same time is safe in clinically appropriate patients. Is that true? Can we do PrEP and PEP, HIV PrEP and Doxy PEP at the same time? True or false? Damon, let's see what people had to say about that. Excellent. Yes. So, in fact, we can and should do both together when it's appropriate. So I'll turn it back over to Dr. Barbie.
Absolutely. Doxy PEP and HIV PrEP go hand in hand. So let's pivot today and talk about doxy as prevention. I'm sure that most of you on this call have heard about DoxyPEP, but let's go back to the studies that gave us the evidence for these guidelines. So DoxyPEP, as Dr. Merman said, is 200 milligrams of doxycycline taken after sex, ideally within 72 hours or even sooner. And there have been 4 large randomized controlled trials, 3 of which were conducted in men who have sex with men and transgender women. And in those 3 trials, very consistently, there was a large reduction in chlamydia and syphilis incidence, so new infections, over 70%, almost up to 90% for chlamydia, and a reduction in gonorrhea in 2 of the 3 trials of about 50%. However, the one study that was conducted among cisgender women in Kisumu, Kenya, did not show reduction in STI incidence among women. And you can see the time to first incident STI on the left. The authors note they think this is probably due to adherence, although the enrolled subjects reported very high adherence per sexual act, about 80%. They used hair studies to look at the concentration of doxycycline in the hair over the time, and it looked like only about 30% of quarterly visits had doxycycline detected in hair samples. And they think that lack of adherence is probably why this wasn't effective. So in June of this year, based on this evidence, we published our clinical guidelines for the use of doxycycline post-exposure prophylaxis for bacterial STI prevention in the United States. And our primary recommendation is that providers should counsel gay, bisexual, and other men who have sex with men and transgender women who have had at least one bacterial STI in the past 12 months about the benefits and harms of DoxyPEP and prescribe DoxyPEP through shared decision-making. When prescribed, it is 200 milligrams taken once orally within 72 hours of oral, vaginal, or anal sex. And we gave this a very strong recommendation of an A1. We offered a little bit of additional guidance, which means saying that any formulation of doxycycline is acceptable, that enough doxycycline should be prescribed for that individual to last until their next visit in 3 to 6 months, and that ongoing need for DoxyPEP should be reassessed every 3 to 6 months between the provider and the patient. It's really important to emphasize that DoxyPEP is one additional tool in the toolbox and really comes as part of what should be an entire comprehensive sexual health approach, meaning other vaccines, other prevention strategies such as condoms, Mpox vaccine, Hep A vaccine, HPV vaccine, HIV PrEP if people are not infected with HIV, and as well as continued screening and treatment every 3 to 6 months. Some of the specific points that we talk about in terms of counseling patients for DoxyPEP on the discussion of the potential benefits as well as known and unknown harms include the benefits we talked about in the reduction in STIs. But we do know that there are some side effects with doxycycline. Phototoxicity, so that means when you're taking doxycycline and you go out in the sun, you're more likely to get a sunburn, so it's important to wear sunscreen. It's also possible to get esophagitis or esophageal discomfort or other gastrointestinal intolerances. It's very important to take doxycycline with a full glass of water and sit upright for about 30 minutes so that you don't get that esophagitis. Some of the unknown harms are a little harder to counsel about, but are important to discuss with your patients. There is the potential for the development of antimicrobial resistance, and we can't really quantify at this point what that means or how that's going to play out or what kind of an impact that's going to have. But this is where we have this unknown in a way. We also don't know what's going to happen to an individual's microbiome. The microbiome is the collection of bacteria that live kind of symbiotically in the body, and that changes when you kill some of the bacteria with antibiotics. But what does that mean for how a person lives their life and potential other infections or issues with their body? We don't know at this point. Our second counseling point is it's important to take doxycycline as it's prescribed and not to share it. And the third is that there are drug interactions with doxycycline and a number of other drugs. We did not list them out in the guidance because there's so many. But every time a provider is prescribing this, they need to ask about other drugs, including over-the-counter medications, and make sure that the patient understands how these interactions may occur. At this time, we cannot give any recommendations for other populations, cisgender women, cisgender hetero men, trans men, or other queer and non-binary individuals. We just don't have the data for it. So at this time, our guidelines are for MSM and transgender women who've had a bacterial STI in the last 12 months. And I think that's what I've got for you all today. Shannon?
Thank you so much. And thanks for all the hard work of your teams in getting this guidance out there to the field. I think we've got one more polling question, and then we're going to jump into some clinical scenarios. So for those of you that are in the world where you've already started prescribing DoxyPEP, what are you finding with your patients? Are they generally declining it because it's new? Are they enthusiastically accepting it most of the time? Do they say yes, but then they don't really come back for follow-up or more prescriptions? Do they say yes and keep coming back? Or I want to include everybody here. Half of you haven't started prescribing it yet, so you can just say we haven't started offering this in clinical practice. So what's your experience in the clinical setting where you are prescribing DoxyPEP right now? Damon, what do people have to say? Interesting. Okay. So, a blend of different reactions, and that's actually been mine as well. My clinical experiences, some people are really enthusiastic. Some people say they'll think about it. Other people are like, I'm going to wait because I just don't know. New things always make me nervous. So that really computes with my experience as well. Okay. Let's hit some clinical scenarios. So first clinical scenario. You've got a 23-year-old uninsured cis male who presents with rectal pain and discharge over the last 24 hours after a recent hookup several days prior. Let's see, I am reading the wrong scenario. It would help if I wrote the right one. Okay, this one is a 23-year-old cis male who has sex with men and women presents to the urgent care with burning on urination. He's had 5 new unprotected partners in the last few weeks, and he rarely uses barrier methods. He's heard of PrEP, but he doesn't have a doctor and he doesn't have health insurance. Based on his symptoms, you've presumptively diagnosed him with NGU and you've given him doxy and ceftriaxone. In this urgent care environment, is he a candidate? Should that provider offer DoxyPEP once the treatment's completed?
I mean, I think it would be great if urgent cares did, but I do think, that's going to be individualized to the center, and it would be hard to do the continuity going up. I do want to make a couple other points on this case, though. I think it would be really important that the urgent, before we even get to the DoxyPEP on this case, it would be really important that the urgent care doesn't just test for gonorrhea and chlamydia with the presentation of urethritis, but we make sure that we're testing at all sites of infection, including the pharynx and the rectum, if he's performing oral sex or bottoming, as well as HIV and syphilis. And then be really important, even if the urgent care doesn't want to prescribe the DoxyPEP or HIV PrEP, they really need to link him to care because he really should be getting HIV PrEP as well.
Yeah, so absolutely on that, and especially on this testing, that when people are presenting to urgent cares or emergency departments, sometimes they're just getting the test focused on their specific symptoms and not more broad STI testing. And we definitely want our urgent cares and emergency departments to do broad testing at all sites of exposure. So let's say this urgent care doc is particularly amazing, gets him into a nearby FQHC to establish care with a buddy he just phones a friend and says, look, I've got this guy, I really need you to see him. And his buddy prescribes him DoxyPEP. And even though the urgent care doc said, don't have unprotected sex until your treatment's completed, he has a new hookup on day 5. So he's wondering, should he take the Doxy-Pep in addition to his NGU dose that he's taking?
I don't think he needs it. He's already getting 200 milligrams that day if he takes 100 in the morning and 100 at night.
All right, so we can let him stick with that and say, hey, next time, wait, friend.
Yes, please.
All right, let's go to our second scenario. You're seeing a 19-year-old cis female college student for a checkup before returning to college. And taking her sexual history, she says she has a few new partners a year that are males, and she uses condoms maybe half the time. She has an IUD for pregnancy prevention. Should she be offered Doxy-Pep?
With our guidelines, I don't think I'd offer her Doxy-Pep. And if we look at the trial, the only trial done in cis women, did not have favorable outcomes. I know that the authors really think this might be adherence, but I do have some concerns about the hair studies. I have to say that the only other study that has looked at doxycycline concentrations in hair were in individuals who took it every single day for about 5 months before they had their hair studies done. So how intermittent use may show up in 1 centimeter of hair, I think we need some more studies on that. And I do know that the authors are doing some more validation studies. They did a letter to the editor in the New England Journal to say that they're still working on hair validation studies.
I think that's a great point. Yeah, I definitely hear that from a lot of people who are concerned about, women's inclusions in the guidelines and where that's going to play out. So more data. We need more data.
I think there's one other point we can make on this case, Shannon. I think, it's great that she has an IUD and she's not going to get pregnant, but in cis women or people who can get pregnant and are not contracepting, you need to be a little bit more careful with a doxycycline because there are recommendations to not use it in pregnancy for some teratogenic harms.
Absolutely. Great flag. Okay, so our next scenario, this is our 28-year-old cis male presents with rectal pain and discharge over the past 24 hours after a recent hookup that he'd had a few days prior. He's sexually active with males only and has all sites of exposure, and he did start having some mild penile burning that started in the waiting room. He's on HIV PrEP and Doxy-Pep, and he describes appropriate use of the medicine. In the office, you're able to do a gram stain of his urethral discharge, and it confirms gonorrhea, and his rectal gnat ends up being positive for rectal gonorrhea. So did he just not take the medicine the way he was supposed to, or was this a prevention failure?
Not at all. This guy's doing everything right. But we know that Doxy-Pep is not going to be as effective for gonorrhea as it is for chlamydia and syphilis. And in all circumstances, it's not 100% guarantee, right? So the studies that we saw, it was about 50% effective for gonorrhea, and we actually saw decreases in that in the data that Dr. Merman was talking about that was presented at CROI this year from San Francisco, that they're not seeing as many decreases in gonorrhea among people who are on Doxy-Pep. So this is somewhat expected because we know that there's already high rates of tetracycline resistance in gonorrhea.
Yeah, I think also for this fella, it also reinforces this follow-up when we're doing Doxy-Pep in the clinic that a lot of people are asymptomatic with rectal gonorrhea or pharyngeal gonorrhea. And so making sure that you're bringing people back into the office for appropriate testing and exposed sites, even when they're taking Doxy-Pep, is probably going to be really important for us. And, kind of making sure that our prescribing also reinforces the need to keep coming back into the office and that people don't feel like they're home free.
Definitely. That's a great point, Shannon.
All right, our next scenario. I love to talk about older adults having sexually transmitted infections. So we've got a 69-year-old cis male who comes to the clinic as a contact to syphilis. He has exclusively male partners, and he enjoys sex clubs and hookups when he's traveling. He's not using any barrier methods and is mainly a top, but he gives and receives oral sex. He's HIV positive and has been virally suppressed for over a decade. Is this someone that you would think about Doxy-Pep for? And are there any specific considerations based on his age?
I think, as a contact to syphilis, I think he probably would be a great candidate. I think that we might need to think a little bit, making some generalities here, but often older adults are on more medications. And so it's one of those places where I would go to Micromedics and I would put in doxycycline and whatever medications, including his HIV medications, which shouldn't really have any interactions, but just put it all in there and make sure that there's nothing we need to be concerned about.
Yeah, I think that's really true that for most of the time we can use all the same treatments in older adults, but there can be some drug interactions that are significant that could really impact your patients. And also looking at their renal function and their liver function, can play into how we use medicine. So just being mindful that those are just boxes we need to check when we're working with our older population in general. But yeah, if he's going out on the cruise ships and having a good time once a year, DoxyPEP might be just what he needs. All right, let's go to our last clinical scenario, and then we're going to open it up to questions and answers. And you guys have not brought abundant questions into the chat. So please, while we're doing our last scenario, throw some questions in there to stump our speakers. So our last scenario is a 16-year-old trans female who presents to your office asking for HIV PrEP. She has frequent new unprotected partners and is exclusively a bottom. Interestingly, though, she's on tetracycline already for acne treatment. So would she be a candidate for DoxyPEP? And what would you recommend for her?
Well, one, I'm really excited that she is empowered and going to get HIV PrEP at this young age. So I'm really excited about that. And so from what I hear from the scenario, she hasn't had a bacterial STI yet. So we can discuss whether she is at risk and needs that, but she is going on HIV PrEP, so probably would be a good thing. But being on tetracycline already, I probably wouldn't add more antibiotics. I'm not sure on her dosage of tetracycline, if it is sufficient, but I might have to have a conversation about kind of choosing one or the other.
Yeah, I think that's a great point. And then, also maybe her primary care or dermatologist might shift and pivot to a different acne treatment that maybe wouldn't have that same sort of conflict with using DoxyPEP as a possibility. But yeah, that one would give me a little pause too in the clinic. And I would probably say we need to think a little more. But how great for a 16-year-old to be proactive and taking charge of sexual health that way. Okay, I believe we are now going to open it up to questions and answers, which I think this is our least question and answer, least questions we've had on one of these presentations. So
it says that the chat is disabled. Someone just put in the Q&A.
Interesting. So in the Q&A, I see a couple questions. We'll start with the ones that I can see, and then I may have been using the wrong word. So if you click on the Q&A, you should be able to put your question in there. Use the Q&A, which is a few buttons over beside the chat function. So Timothy asks about the concern with widespread use of DoxyPEP resulting in increased bacterial resistance. Wouldn't it be better to emphasize screening interval recommendations by sex and population and counseling on risky behaviors? Do one of you want to respond to that?
Sure, I'm happy to, unless you want to, Dr. Merman. Okay. We don't know yet. And there's already a lot of doxycycline being used in the world. And so we don't expect this to be a huge increase in the amount of doxycycline use. It is certainly possible that we're going to see increases in bacterial resistance. And we don't really have a trial to say that the increase in bacterial resistance versus screening and treating. We're still screening and treating a lot of infections under the current kind of paradigm of screen and treat for prevention. You want to add? You're muted.
You're on mute, John.
Yeah, I am muted, but I don't mean to be. This is really a ongoing question, and I appreciate Timothy bringing it up. We are monitoring for antimicrobial resistance changes and microbiome changes in the people taking DoxyPEP, and then also thinking about how it might affect the community. I will say of note that we aren't really concerned about increasing tetracycline resistance for STIs, because gonorrhea, we already recommend alternative treatment because there is already resistance. And for scientific reasons, we don't expect resistance to occur for treponema pallidum or chlamydia. So in that regard, it really is this kind of, will this increase change this concept of antimicrobial stewardship? And so we are watching that. I mean, it's a fairly restricted population, as Dr. Barbie had mentioned. It's not going to have a major impact on the overall doxycycline use in the community, especially when you take into account agricultural use. However, if the guidelines do expand to broader populations, you could expect that it might be used more. So we are trying to answer the scientific questions now. I would also like just to say that we do emphasize the screening interval recommendations and counseling and reductions, and have been doing that for at least a decade while we've been failing. So I think we are now at the situation where the potential benefits of carefully and thoughtfully expanding DoxyPEP in the appropriate populations with careful consultation between patients and clinicians is the right way to go, while we continue to monitor, because otherwise we're just, the increasing syphilis cases are overwhelming to the system and harming people.
Yeah, absolutely. There's another question in the chat or in the question and answer that I think is a great question. And as someone who's working on the guidelines for the health department that I work in on how we're going to push out DoxyPEP amongst our population, is what's the standard of care looking like? And Chris asks, is it like giving 4 doses for patients to use as needed? Or are you giving a single dose to keep at home? I will say the patients I take care of have way more sex than that. So is there a standard yet of like, what's the right amount for a prescriber to give it in one prescription? Or what are you hearing anecdotally in the field about what people are doing?
I'll turn to Dr. Barbie for this too, but I would just say that intentionally, we expected people to take a pack of pills home to be able to rapidly access this intervention and not have to go to a doctor. It is different, for example, than HIV post-exposure prophylaxis. And in the clinical trials, the average number of doxy doses used per month was about 4. Some people more frequently, some people less frequently. So it's going to be individual about how many pills are prescribed, and do you kind of, and how often you are kind of replenishing the supply of doxy, along with STI screening for your patients. But I turn to Dr. Barbie too for her thoughts.
Yeah, no, that's exactly right, Dr. Merman, that it's really individualized. And if we went by the trials and having people come back every 4 months, you're going to give about, 4 doses per month or 12 doses. But I don't think, I think it depends, because that range on how many times people were using it was, up to 10 times a month. So maybe people need a bottle of 30 doses to get them for the next 3 months or more. And that's why it's really important that providers have that conversation with their patients.
Yeah, I think it reinforces this sort of creating a safe and trusting environment where people can feel really comfortable telling you what their risks are and how often they're engaging in risky behavior, so that you can make sure you meet them where they are. And we also don't want them rationing. We certainly don't want them to have to call for refills in order to get it, because in the moment is when people need it. So I've heard a variety of how different people are doing it. So I'll have to be putting our recommendations together for our health department. Are there any health departments that you would point people to that have been really generous with their resources and with DoxyPEP that you can think of off the top of your head, where you might say they put everything out online and feel free to kind of take and steal from them?
I'm not sure if they have things online, but San Francisco, put together guidance in November of 2022, and they have been doing this for a long time. So I think they would be a great resource.
I think that's probably exactly who I'm going to. All right. So another really good question from Andrea about who's covering the cost of DoxyPEP for the uninsured. I will just answer from my lens in a health department. We are going to be covering it as part of our sexual health services and our STI clinic at no cost for patients. As far as I understand, it is fairly inexpensive for us on 340B drug pricing standpoint. I think it's different when you don't have access to 340B drug pricing and what's going to happen to people. So I think making sure that they're uninsured, they have access to a federally qualified health center or some other partner that gets their public health department that has access to a 340B reduce costs is probably going to be important to make sure that uninsured folks are included in this. Jono or Lindley, anything you'd add to that? Okay.
I think it should be on the $4 med list, right?
I'm not sure, but it goes on and off because there was shortages for a while and then there weren't. And I'm terrible at keeping up with that. In a perfect world, it would be. Desiree wants to know what would be the requirements for local ERs and urgent care clinics to offer a broader range of screenings, and is there additional funding? Is it based on signs or symptoms? And then it references syphilis as the great imitator, which is so true. I wore an urgent care hat for a few years when my kids were little, and I took care of so many STIs in the urgent care environment. A lot of people feel really safe, especially if they're in kind of smaller communities and they know the people at the health department and they like stand in the choir next to their primary care doc. They might not really want to go and get their sexual health screenings in that environment. So urgent cares and emergency departments, urgent cares probably more so, can be really important sexual health spaces in communities where people feel trusted. Payers are going to reimburse for this. So these are reimbursable codes and billing. If you're uninsured, of course, you've got the whole uninsured challenge that goes with it. But I would say we desperately need our urgent cares and emergency departments to engage in comprehensive testing for sexually transmitted infections. But John O'Lindley, do you want to add anything?
I would just say that so we're diverting a little bit of the conversation. So I would say absolutely, and we have lots of thoughts about why the neglect of STIs in the nation and how we want to change that. But I would say one of the beautiful things about the guidelines that Dr. Barbie had highlighted is that they really start with, you've been diagnosed with an STI. What should be our standard counseling? And for the populations where doxypep would be, an option, it should be a routine thing to talk about it. Now, that could include if you're diagnosed in ER or urgent care, which a fair proportion of our STIs are. It could be a primary care clinic. It could be other, an STI clinic. It could be other sites. So it's really just that would be. So we do need to increase screening. We do need to increase symptom-based testing, but we do need to perinatal testing, all sorts of stuff. But in this case, it's really, what do we do for someone who's just been diagnosed with chlamydia, gonorrhea, or syphilis? What kind of counseling would they benefit from? And I think this is a new thing to talk about. A lot of people, it won't be the right thing, especially if they don't anticipate future, a risk. But if someone's had multiple STIs, or they do anticipate increased risk, especially for some, it can be very intermittent. I'm on a cruise twice a year. It can be potentially very beneficial to have this as an option, and we'll learn more about how to operationalize it as we get more experience.
Lindley, anything to add there, or you want me to go on to the next one?
No.
Okay. There is a question, so this kind of follows up on Jono's comments about what guidance are you giving people who are diagnosed with a confirmed case of chlamydia as far as abstinence? What are you asking them to do?
This would be abstinence while they're
on treatment.
While they're on
treatment.
Yeah,
so while they're being.
Lindley, go right ahead.
Yeah, I mean, this question comes up a lot, especially when we move to doxycycline for chlamydia treatment primarily, as opposed to a single dose with azithromycin. And I think what we came upon as a group of experts was to say 7 days after the completion of the doxycycline, which, yes, is a 2-week time period.
Which is a long time for people. And I suspect, and the counseling I give personally to my patients is, if you know that there's no way you're going to go that long, then at least use barrier methods, in the interim time. It's because, people have lives. So there's another great question around online HIV PrEP services. Is online DoxyPEP available? I don't know why it wouldn't be. It's, in the setting of being in an established, medical prescribing relationship, as long as people are following their board guidelines and other things. As far as any specific, I'm not aware of any specific online resources for that. But Jono, Lindley, you're hearing anything about that?
I have seen at least one site. I can't remember the name of it and who it was, but yeah, it's out there. Google.
And it's being expanded. It's an area of potential interest.
Yeah, it makes
But
it makes
do
great
bear in
sense.
mind if it might be more expensive if there's copays and because it then alternative access, but it does deal with some of the stigma and other issues that may be barriers.
So then there's a question from Andy in here. Andy's a prep navigator and is struggling to get patients on board, providers, sorry, not patients, providers on board with prescribing Doxy-PEP. Any tips? So here's your like elevator. What are you going to say to somebody when you run into them in the elevator at a meeting and you're trying to convince them to start doing Doxy-PEP?
Well, I'm curious to hear more from Andy about what the providers' concerns are, because I think that's where you're going to really have to address it. But I think we can always bring it back to the patient. And if the patient's asking for Doxy-PEP, you need to be, you need to counsel them and talk to them about their individual need and risk. But we need to be patient-centered.
Yeah, I guess first, great, Andy. What a great job. And thank you for doing that. I actually think it's how do we normalize new interventions? So if I were talking to a provider of PrEP, HIV PrEP, you can remind them that, 6 years ago, they were in the same situation. PrEP had been available, but it wasn't being used. We didn't understand why it wasn't prescribed. People were fearful of it. They didn't know how well it would work. There were issues about adherence. There's some of the studies, as we all remember, showed less efficacy during the randomized trials of PrEP than in the real world. Because when people knew they were taking it for prevention. And now we even have, more effective agents. We have, long-acting PrEP. So I think things have changed as PrEP became normalized. And now we have several 100,000 of people who've gotten prescriptions each year. Ideally, we'd like to increase that. So in some ways, we're dealing with that with now Doxy-PEP. It has different concerns about antimicrobial resistance, although there was antiretroviral resistance concerns with PrEP and still is. I think it's really just that when does it become standard to at least talk about it? Just as we talk about other issues, how did you get STIs? We talk about contraception in the appropriate situations. We talk about PrEP or HIV screening in other situations. I think as this becomes more normalized, providers will become more comfortable prescribing it. And it may be that some are more comfortable initially, and may always be more comfortable talking about it. But if you're prescribing HIV PrEP, it's a wonderful situation to add on Doxy-PEP for some, for patients where it's appropriate. And I think that the patients really like it, and they're used to taking a medication to prevent an infection already. So they're kind of already ready for that, and honestly are at risk for HIV. They're also at risk for STIs in the same kind of community situation. So normalization over time, and then your creative effort to answer the questions, as Dr. Barbie had said, that they might have, and then also kind of ask them to try it, see if it works with certain patients, and then learn from it about what they need to do. But it will become more normal in some situations where it's appropriate, and ideally we'll also have more information from the scientific analyses to know, is it really working, and what's happening to the communities where we've introduced Doxy-PEP at scale.
Yeah, I think that, and Andy followed up with building resistance to antibiotics. And it is a really tough environment to be in healthcare, right? You get chastised if you prescribe for bronchitis or if you prescribe for pharyngitis. And now we're saying, give everybody antibiotics for having sex. I mean, it does create, which is not what we're saying, to be clear. It does create this sort of conundrum for prescribers about, okay, wait a second, are we worried about resistance or are we not worried about resistance? I would say the people that are getting Doxy-PEP are the people that are coming in and getting antibiotics anyway. They're getting infected. And so you're really saving them the potential complications down the road of untreated infections. Right. And you're honestly freeing up space in a resource constrained environment for more people to access care, because you're not having them come in frequently with infections.
And I think ideally providers will understand that although the initial data that is not of a huge wealth of information, but the initial data shows that concerns about antimicrobial resistance in people taking Doxy-PEP are minimal. And we are continuing to assess the situation over time. And so you can share that it seems okay at this point, and we'll continue to monitor it. But it does seem like you're still a prudent use of antibiotics. It's not an inappropriate one, like you're giving, antibiotics for a viral respiratory infection. I mean, this is really a situation where it works partially, and has shown to be beneficial for some people. So I don't think it's a clear-cut answer. It's not like this is the chemotherapy regimen that we use for this cancer. It's really more, this is an option that seems to work and seems to have minimal negative effects at this point, and we'll know more over the next few months to years.
Absolutely. Fantastic. Any final parting remarks, Lindley, before we go to our last few slides?
No, I mean, I think this has been fun, Shannon. I think, doxycycline is a great drug. It's doing, it's always been our backup for syphilis. When we've had multiple, bicillin shortages and for people with allergies, and we can rely on it for that. We can rely on it now for doxypep to prevent STIs as well. So
great. And we will keep learning. Fantastic. Damon, if you could pull the slides back up for our last few slides. Just a reminder, we've got 2 more sessions coming up next week. We hope you'll join us for talking about syphilis partnerships with the Indian Country Congenital Syphilis Task Force findings. And then September 10th, Future Forward, Emerging Trends in the Syphilis Syndemic. So 2 great webinars still to come. You can scan this QR code and go to our website where you can find more resources. You can find slide decks from our other webinars. You can find some letters around federal agency funding flexibilities and other professional resources around syphilis and congenital syphilis. And as always, if you have questions for us or things you just want to say, shoot us an email at sti@hhs.gov. Or if you're finding challenges with accessing benzathine, penicillin, bicillin, we want to hear about it. And by that, I mean the CDC. So CDC shortage or STD shortages at cdc.gov. They really want to know if you're having trouble accessing bicillin. We don't think people are. And so if something different is happening out there in the world, please let us know. Thank you so much for spending time with us today. Thank you, Jono and Lindley, for your expertise and your hard work in this space, and to all of you out there in the field doing what you do every day. And we look forward to seeing you next week with our webinar.